Let's now discuss deep gluteal pain syndrome. Deep gluteal pain syndrome used to be called piriformis syndrome. In fact, it has been called piriformis syndrome up until very recently, around 2019, is when we started to switch and call it deep gluteal pain syndrome. Now, the main reason why is, for the longest time, we believed the primary culprit with deep gluteal pain syndrome was indeed the piriformis muscle. However, now what we are seeing is that it's more than simply the piriformis. It is in fact any of the external rotators, as well as, potentially, gluteus medius and gluteus minimus. Additionally, what we now understand is, with piriformis, we primarily suspected it was a compression of the sciatic nerve. Now we understand that not only the sciatic nerve can be compressed, and also, if somebody has a deep gluteal pain syndrome, they may have all of the aching pain and discomfort within the gluteal region without any neurological symptoms. Piriformis syndrome required the presence of neurological symptoms as well as aching pain within the gluteal region. Deep gluteal pain syndrome now encompasses a broader range of pain and discomfort. So let's move forward now by discussing deep gluteal pain syndrome. We begin by taking a look at this image. So this first image is indeed just the piriformis, and I largely show it so you can see the general trajectory of the sciatic nerve. It does indeed go underneath the piriformis, but it also goes over top of quadratus femoris. So this is part of the reason why it was called piriformis syndrome for a long time, is because the sciatic nerve can quite easily be compressed between the piriformis and quadratus femoris. However, we do indeed need to dig a little bit deeper into our anatomy. Looking at this image, we begin to see that there is much more going on. Now, at first, it can look quite chaotic and difficult to understand. However, if we take a moment and we start to follow the labels and really look at what we are seeing, we begin to understand that it's actually not quite so complicated. Of course, the first thing that's worth understanding and noting is the same thing we saw in the last image, which is the piriformis, the sciatic nerve, and the quadratus femoris. Those structures will be our landmarks as we explore the rest of the deep gluteal region. The next thing I would like you to notice is this nerve right here. This nerve is called the superior gluteal nerve. Notice that the superior gluteal nerve goes superior to the piriformis and inferior or underneath gluteus minimus. And note that it terminates within gluteus medius. So if an individual had a hypertonic piriformis, we can now see that it's not just the sciatic nerve that could potentially be compressed, therefore causing symptoms. We can indeed see that compression of the superior gluteal nerve is possible, causing pain within gluteus medius. So that might lead to something called Trendelenburg gait, which we did indeed discuss within our foundations of orthopedic assessment. Let's dig a little deeper in this image. The next nerve I would like to draw your attention to is the inferior gluteal nerve. The inferior gluteal nerve follows the same trajectory as the sciatic nerve, going underneath the piriformis muscle. However, unlike the sciatic nerve, which then goes down the posterior aspect of the leg, the inferior gluteal nerve innervates gluteus maximus. As it innervates gluteus maximus, we can now see that if there is compression upon the sciatic nerve, or if there is hypertonicity or dysfunction within the deep gluteal region, and it compresses upon the inferior gluteal nerve, it would then cause gluteus maximus dysfunction, potentially leading to weakness within the gluteus maximus. And then we would maybe see the glute max gait, which again we did discuss within our foundations of orthopedic assessment. Now there is indeed more. Let's continue our exploration through that diagram. The next nerve that's worth noting is going to be the posterior femoral cutaneous nerve. The posterior femoral cutaneous nerve within this image is transected, so you can see a small portion of it right beside the piriformis. And then we can pick up the trajectory inferior to the piriformis as it then follows the same pathway as the sciatic nerve, going down the posterior aspect of the leg. Now what's interesting about this is the sciatic nerve, that large nerve which we're all familiar with, goes down the posterior aspect of the leg, then terminates on the bottom of the foot and the big toe. The posterior femoral cutaneous nerve, on the other hand, goes down the back of the leg and terminates just superior to the knee. Now there's a very important reason why we need to understand this. If somebody has deep gluteal pain syndrome, to an extent that compresses upon the nerves, if it is compressing upon the posterior femoral cutaneous nerve, the sensation will only go down to the back of the knee. On the other hand, if it's compressing upon the sciatic nerve, the sensation will go all the way down the leg and then terminate in the foot. Now, does this really matter when it comes to treatment? Well, quite frankly, no. Because within deep gluteal pain syndrome, the location of compression doesn't really matter. We treat it all the same. So what all of this is to say is we really need to be clear on the fact that piriformis syndrome is not such a simple dysfunction, which is why we call it deep gluteal pain syndrome. And if I were to summarize this entire discussion as best as possible, it would be that hypertonicity and dysfunction within the deep gluteal region has a potential of compressing multiple different nerves, therefore causing neurological symptoms in many different areas. In addition, it is absolutely possible to have deep gluteal pain syndrome without any neurological symptoms. We can have hypertonicity or pain within these deep gluteal muscles, and it is not severe or significant enough to compress upon nerves. We simply have deep, localized pain within the gluteal region. Potentially, it may manifest later down the road as neurological dysfunction. However, I want to make sure you understand the difference between deep gluteal pain syndrome and what we used to call piriformis syndrome. Now that we have a fairly detailed understanding of the mechanism looking deep, let's look at what could possibly cause this. So then within our history, we will have hip and low back pain. That's to be expected, and the pain will indeed be within the hip. They'll oftentimes point to their gluteal region quite specifically. If there is an inclusion of a nerve, they would then complain of neurological symptoms based on whichever nerve is being compressed. Maybe it's dysfunction or pain on the lateral side of the hip, the superior gluteal nerve. Or maybe they feel that their glute max is just not as strong as the other one, inferior gluteal nerve. Maybe they experience neurological sensation going down to the back of the leg and terminating just superior to the knee, the posterior femoral cutaneous nerve. Or maybe lastly, it is indeed going all the way down to the bottom of the foot. Indeed, it is then sciatic nerve. Again, the precise pathway and innervation region, or the zone that is being affected, doesn't matter when it comes to treatment. Just bear in mind that we can have multiple different manifestations of deep gluteal pain syndrome. Hip and low back pain, though, is going to be the first complaint. It's oftentimes made worse by sitting for long periods, being in a cross-legged position in particular. So sitting for long periods of time is either going to stretch these deep gluteal muscles or compress them. Either way, if we sit for long periods of time, it will increase the amount of aching sensation within the gluteal region, and if there are neurological symptoms, it oftentimes will aggravate those neurological symptoms. It can be caused by things such as chronic external pressure, hypertonicity due to postural dysfunctions, maybe SI joint dysfunction, acute impact. When we look at external pressure, this would be something like maybe sitting on a wallet. All day, every day you sit on a wallet, it would compress upon the deep gluteal muscles, therefore causing pain and dysfunction. A common postural dysfunction could be something like anterior pelvic tilt. As the pelvis tilts anteriorly, as we understand, we will have our deep hip flexors are hypertonic and our lumbar extensors are hypertonic. As such, we may have a disruption in the stability of the pelvis. And as we know, when a joint becomes unstable, all of the muscles affecting the joint become hypertonic to stabilize it. And in this case, some of these muscles are going to be the external rotators or the deep hip muscles. In that same breath, SI joint dysfunction could lead to deep gluteal pain syndrome. Within SI joint dysfunction, we know that there's an instability within the pelvis, and the same rule applies. All of the muscles affecting it become hypertonic, which means the external rotators or the deep gluteal muscles become hypertonic, which could eventually lead to deep gluteal pain syndrome. It is important to note that gluteus medius trigger points can reproduce very similar symptoms. So one may not have deep gluteal pain syndrome. They may in fact have just tight hips from maybe an occupation, or perhaps it's a recreational activity that causes their gluteus medius to become incredibly hypertonic. This is not deep gluteal pain syndrome. What we would see is when we press on the gluteus medius, it can replicate many of the symptoms because the referral pattern within the glute med goes into the glute and also down the back of the leg, and in some cases all the way to the foot. So differentiate between the two, and we largely do so by, if it is indeed a trigger point, we press on the trigger point and we would expect our predictable referral pattern. Observationally, there's really no specific findings, and within palpation of the region can replicate symptoms. This is indeed and absolutely the case. I have found that palpation is actually one of our most important diagnostic tools when it comes to deep gluteal pain syndrome. An individual who has deep gluteal pain syndrome is going to have very sensitive glute muscles. It does not take very much pressure at all in order to elicit a twitch response where your client may jump or move around on the table. So palpation is a highly indicative sign of deep gluteal pain syndrome. We also see the muscles of the hip are likely to be hypertonic, which of course makes sense based on all of the theory we've just discussed. Let's move on to our range of motion and special tests. To start with, within active range of motion, there's possible weakness and neurological symptoms with abduction and lateral rotation. The deep gluteal muscles, for the most part, are external rotators or lateral rotators. So with deep gluteal pain syndrome, we would indeed see potentially pain and weakness during that lateral or external rotation as we contract those potentially dysfunctional muscles. Within passive range of motion, we really don't see anything specific. Within resisted range of motion, we see the same thing that we saw with an active range of motion. That's possible weakness and neurological symptoms with abduction and lateral rotation for the same reasons as active range of motion. There are indeed two special tests, which are the piriformis test and the pace abduction test. The piriformis test, yes, it is called the piriformis test, but it's important to note that the test applies to deep gluteal pain syndrome because, as we know, deep gluteal pain syndrome is largely the external rotators, of which the piriformis is of course one. Let's take a look at those tests.